want to welcome all who are joining us today. We felt it was necessary to gather so we can update everyone on a multitude of topics that affect us as a region. We find that things change rapidly these days, so we're not always to give several weeks notice before a meeting such as this. And with that said, we appreciate your attendance today. These meetings are recorded and we will be placing them on the ODEMSA website for those that wish to listen later. So again, I want to thank you all for participating today. And with that, I'll turn it over to Dr. Yee.
Go down the kind of the agendas. The CDC guidelines still essentially haven't changed for COVID. 99% of the COVID cases right now are the Delta variant. Every state essentially has the Mu variant. Right now, Virginia is actually doing fairly well in terms of Delta. If you look at the R prime number for Virginia, so that's for every one case of COVID, how many they infect, we just went below 1. So we're likely that we should be, this should indicate that we're on the down slope of the peak. Thank goodness. Some jurisdictions are slightly ahead of others. And since this is the 16th of September, we should be past the spike that we would have seen for the Labor Day weekend. However, some jurisdictions just went back to school this week, so we may see a little bit of a rise in some jurisdictions. Otherwise, in terms of Delta, there's also the Department of Labor and Industry standards. So that way, just to reiterate them, we as agencies really are required to be wearing masks at all times when we can't socially distance. That's at the workplace. At home, there's a little bit more latitude because the Dolly standards don't apply, right? So many of us don't wear masks at home, but in the workplace, technically speaking, we are supposed to be wearing masks when we can't socially distance. For the 24-hour service, for the fire services, it's much more difficult. I mean, and quite honestly, sometimes just doesn't make sense. Recognize that you could be wearing a mask, around the stations, and then go to lunch and everyone's taking off the mask to do the rest of the day. And then when it's time to go to bed, you're sleeping within 6 feet next from your coworker without a mask. So there is some. I don't think that the regulations take into account 24-hour services or EMS in general. But technically speaking, we are supposed to be wearing masks 24. Well, when we can't socially distance. The hospitals still require us to wear a mask and put a mask on a patient when we enter the hospital. So don't forget that. And also some changes in the Department of Labor and Industry standards now. It used to be when there was 3 infections at a workplace, i.e. a station or single work site, you had to fill out the Department of Labor and Industry report. When we looked earlier this week, it's actually the number is now 2. So that's a little bit of a change. All right. Any questions so far on the COVID itself? All right. Seeing no questions, I don't see anything in the chat, don't see any hands up. We'll move on to boosters. Boosters are unfortunately very controversial. The White House announced the booster program last month and said it would go live on September 20th. However, when the White House announced it, and holds true today, none of the vaccine manufacturers are FDA approved for booster administration.
Hey, Alan, we've lost you after the FDA.
Sorry. So let me go backwards. So boosters are a little bit controversial. The White House did make an announcement. It's a little premature that these boosters are not FDA approved. Pfizer and Moderna have submitted data for boosters to the FDA for review. I believe that they are reviewing the Pfizer data this week and with a decision no earlier than next week. Moderna should be following it in the next several weeks. And there's no real word on J&J and what they're going to do. The Pfizer and the Moderna right now, from what is being proposed, are the exact same shots that you got in the first 2 rounds. Now, that's the booster shot. There's a difference between a booster and a third shot. So if you're a immunocompromised, let's say you have a transplant, or you're on medicines for Crohn's disease, one of the biologicals, they consider you're considered immunosuppressed, and you can get a third dose of the booster. That is, I'm sorry, a third dose of the vaccine, which is not considered the booster. The booster is, I'm immunocompetent and I'm getting a third shot. That is not approved. So if you have some disease or you're on medicines, then you can get a third shot whenever you can go to CVS or wherever and get it. If you're immunocompetent, you're healthy, technically you still have to wait. I do anticipate the Pfizer to pass because of the political pressure. I will fully admit, there is some evidence that not everyone needs a booster shot. Clearly, some folks need a booster, but others don't, and it's unclear which group we are. It's also clear that the antibodies in your system drop over time. The question really is, yes, they drop, but are the antibodies still enough to fight off an infection? So there's still a lot of questions for the FDA and the CDC to sort through before the approval at the earliest next week. Any questions on the boosters? All right, next topic, infectious diseases. Earlier in the week, we got notified that there was some measles in the Central Virginia area. When we first found out, there were 4 cases in Northern Virginia and 1 case in Central. These are from those that were evacuated from Afghanistan. They were isolated to, I believe, 1 military base. We learned yesterday, and it was confirmed that we now have 3 cases of measles in Central Virginia. Measles essentially is a very highly contagious disease. Their R factor is 15, so for every 1 case, you expect to infect 15 others. In unvaccinated individuals, 15 unvaccinated. Most of us are, in fact, if not all of us, are vaccinated. A single dose of MMR vaccine, mumps, measles, rubella vaccine, is somewhere on that 92% effective from preventing the disease. Many of us got a dose as an adult. I think they recommend if you're born after 1957, you got a second dose. Then in part 2, I believe, was 97 or 98% immune to the measles. So it's highly unlikely that if we were to take care of measles, that we would actually contract the disease. However, it is still highly infectious, and there are some serious complications. So when we put out the information, we recommend that if you suspect a case of measles, someone with fever, runny nose, loss of taste, same thing, same symptoms as COVID, and they were a refugee, then what we suggested is you treat that as measles, and you wear N95, goggles, and gowns, right? Within the same population, there's been other diseases that have been noted. I believe there's also mumps, TB, and COVID. So just be on the lookout for febrile individuals. Any questions on infectious disease? All right, turn it over to Ryan.
Thanks, Alan. As of today, we have 1,200 tests on hand that are in date. So if your agency has previously done antigen testing using the Bionox COVID-19 AG cards, we do have more in stock. If you need them, please email me. My email address is right there on the screen, rscarborough@vaems.org. If you're an agency that has not gotten the antigen testing for COVID, and you would like to do that, the OEMS guidance document is on our website under the COVID tab. And just as a reminder, testing does require OMD to oversee the program, and also for us to have a signature on the Appendix A with us. And also, you don't have to worry about having a CLIA waiver if you're an agency in the ODEMSA region, because you're covered under our CLIA waiver for these tests. If you need any additional information on COVID testing for your agency, please visit our website /COVID-19. And anybody have any questions about that?
Ryan, have we sorted out whether whether the regulations on using a PCR test was removed under the Department of Labor and Industry standard? Because
the last I heard, it has not. Because I know these tests are being over the counter now.
All right. So this would be a good test as a confirmatory test or a prelim test for your organizations then. It's also a good test for exposures, right? Because the Department of Labor and Industry standards require a PCR testing for symptomatic patients.
Correct. And just as a reminder, these tests will only detect if the person being tested is positive within the first 72 hours of symptoms. Anything past that, it's kind of up in the air whether or not it'll come back positive or negative. Okay, so just a real quick rundown, just to reiterate everything that we know about the diversion statuses as we go into this portion. Everybody knows what Code Green is. That's our normal operations where providers are just calling hospitals directly. Code Red is when we have 6 or more hospitals on diversion. At that point, we are trying to divert ambulances away from facilities that are on diversion so that they can hopefully decompress and come off diversion at that time. Then we look at the numbers and we'll eventually go back to green. If we see an increase up to 8 hospitals or more on diversion, that's when we go on Code Black, and that's where we're currently setting. At this point, when we're on Code Black, your diversion status or the hospital diversion status, while it means something to us, when we're distributing patients, there is we're only trying to evenly distribute the patients across all facilities, including the freestanding EDs within our region. And that's to spread the load across the system so we can hopefully go back down to Code Red or Green. It's been widely thought over the years that when we're on Code Black that we do what's like a round robin sort of disbursement of units across the system by going down a list of facilities. But if we actually did that, we would be sending trucks from New Kent all the way across the region to Halifax, or trucks from Hanover all the way down to Emporia. So it actually doesn't work exactly that way. And in fact, we try to take the patient's choice into consideration when we're determining a transport destination for them. And there's a lot more that actually goes into it. And I'll let Heidi talk more about that when we get to some more information on the PDC. And then just as a note, when we're on Code Red or Black, that is system wide. We don't discern between pediatrics or adults. Every facility is open to receive patients at that point, and it's not dependent upon where they fall, either pediatrics or adults. The next thing we got is the overview of the numbers to date. As of yesterday, so far between VCU and ODEMSA doing the patient distribution center, since it's a month today actually, we've done 9,745 patient distributions, and of that, 7,947 have been green patients, 1,539 have been yellow patients, and 259 have been red patients that have been reported to us. From this data, this is from the week of 9/5 through 9/11 and includes all the data that was in BHOS for ODEMSA and VCU patient distribution centers. And as you can see, those peaks on that chart are showing our peak times in the patient distribution centers. And usually that's anywhere between 11 a.m. and 3 p.m. on most days. All right, with that, I'm going to turn it back over to Heidi.
Thank you, Ryan. So unless you're doing an interfacility transfer, all ambulances should contact the PDC each time they transport. It doesn't matter what part of the region you're in. If you feel like you're in an area of our region and it only has one close hospital, we still need you to call. It's very important because we may be sending ambulances from another part of the region there, and we don't know what we can't see. So we do appreciate all agencies calling the PDC each time. The AIC should call, but we understand sometimes you're too busy. And if that's the case, we ask that the communications call and update us. The PDC only needs a few bits of information in order to determine destination. Once we have that information, which is the age of the patient, the sex, chief complaint, triage color, your unit number and name, we'll determine what hospital is best. And we do that by working with the AIC also, by asking what their first choice is always. Once you have contacted the PDC and you've been given a destination, you must also call the hospital to give them your actual patient report. When do you call the PDC? Call the PDC before you transport to get the destination. If your patient is in extremis, PDC still needs to know that. The call can be quick, and again, your comms can call as well. Again, Ryan touched on this, but traditionally, PDC is run from the VCU communications room. Because of the extreme circumstances, ODEMSA has been manning a center from our office on Parham Road. ODEMSA does this during peak times, Monday through Friday, 11 a.m. to 11 p.m. So we are very much working in partnership to get ambulances to hospitals. And I want to thank the folks at VCU for quickly training my staff so we can assist in this effort and their continued day-to-day communication with us. I also want to thank the CVHC for bringing over some equipment. As you can see in the picture here, much of that equipment does not belong to us. It's been borrowed. And we thank CVHC for lending us some of that. This is what Ryan touched on earlier. Patients are indeed, they are not distributed evenly in a round robin type rotation. If we were to do that, if we did that, we would be sending ambulances all over the region and many times outside their service areas. Instead, it's based on hospital beds and some other factors. We distribute the patients to hospitals based on a predetermined number of patients they can receive per an hour. Many factors play into that decision, including the patient's choice of where they want to go, the injury or illness to the patient, the service area of the agency calling. And I must say, most times, I would say well over probably 80% of the time, we're able to get the ambulances to the first choice they request. And even a higher percentage then can get within their first or second choice of hospital that they request. We are aware of agencies not calling. By not calling, this really messes with the entire system. I would like to give you an example that happened to me just last night. We received a call from a hospital asking us to please have some mercy on them. And when we looked at our notes, we had not sent an ambulance to them in 2 hours. So the ambulances that they had in their bay were not sent from the PDC. And if you can imagine, if this is happening in all the hospitals, you know, this will not help the patient distribution system work at all. So it's extremely important to call. We will work with the provider. If you want to go to a certain hospital and we try to direct you elsewhere, we will work with you if we know the special circumstances that exist. So it's if there are some, we advise you to let the PDC know so that we can work with you, and we do. You know, the goal is to get ambulances back in service as quickly as possible, and not parked in hospital hallways. We do believe that the code black status and red when we have to use it, we believe they work. We are hearing that from providers and from hospitals alike. But we do also value your comments, and with that, we would like to know what you think. So thank you.
Hey, this is Summer. Can I ask a question real quick about the PDC?
Yes, ma'am.
So one of the concerns that's come up is when the PDC distributes the truck to go to a certain site, there are sites that are turning the trucks away as they're trying to call report. What is the follow-up from that? Is there a call to that hospital's administration? Like, what happens? Because we're hearing that that's happened multiple times.
Yes, ma'am. When I can tell you, when I find out about it, if I have the details, I do call. Yes, ma'am.
Okay.
But I can also say many times I hear about it after the fact. I don't sometimes know, you know, what the unit was or the exact circumstances, but if I can get that, I do call. Later, Ryan is going to talk about a feedback form, and that would be helpful to fill that out each time that happens.
Okay, great.
Hey, Summer, this is Alan. So I think at the agency level, we're also following up with the hospitals when we know about it. It's happened several times. I mean, it's not often that happens, but it has happened.
I don't spend a lot of time in the ED. I have been spending more lately because it's been so crazy. It's happened enough that like the crews are talking to me about it. So that's where I'm like, you know, we just got to make sure everybody's playing in the sandbox, and we know that everybody's very challenged right now, but we want to make sure, you know, the goal of the PDC is they're truly sending, like, it's a round robin. So if that's happening, we just want to make sure that feedback is getting to that administration, because we really cannot refuse when the PDC is sending us a patient. So
I can tell you in Chesterfield, we've not had an issue for at least several days. So that's good.
Okay, good.
Yeah.
Good.
Heidi, and there was a couple things I wanted to add to what you were saying. And it's more for providers who may catch this when they play it back, that are bordering our region. If we have agencies that are transporting into the Odemsa region from outside, they should be contacting the PDC as well. And then just as a reminder to providers, when you do call, please stay on the line. We are working as fast as we can to get to your call. And then once we do answer, please be ready to get that information to us, be quick and succinct with it, because we're receiving a call during peak times every 30 seconds to a minute. And we have 2 people in our center right now, and VCU only staffs with 1. And so we are working as quickly as we can. So please stay on the line. And that's all I have to add to what you had, Heidi.
Thank you, Ryan.
And then moving on into the PDC EMS feedback. Between the Central Virginia Hospital Coalition, or the CVHC, and Odemsa, we've come up with a regional diversion feedback form. It is on our website. We're asking agencies and providers and agency administration, if you have any issues while we're doing patient distribution, to please fill out this form, and it will be put into a system where we can monitor, follow up, and answer any questions that may come through there. This is just giving us more of a way to get information to everybody that needs to get it versus this person calling that person, and then it eventually making it to where it needs to be. This also gives us a place to be able to track that data as well, so we can note any problems with any specific agencies or facilities. So on the EMS side, there is a form. And then also on the hospital side, there is a form as well. I believe you can either go to the ODEMSA, or I know you for a fact you can go to the ODEMSA website to find that form. And it's on our main page. The image is right there on the screen. It says patient distribution, EMS feedback. Click that link and scroll to the bottom. There's two buttons, one for EMS providers and for agencies and admin. And then there's a second button for hospitals. So hospitals that are on the line with us today, if you have any issues, please feel free to fill out that form as well. And we will do our best to fix any issues that we come across. And with that, I'll turn it back over to Heidi.
Ryan, just 1 second. Hey, just want to say one thing. The whole system is stressed. What we cannot let happen is that EMS gets frustrated and starts yelling at the ED staff. Now I'm in a position where I get to see both sides. And I can tell you, I have never seen the ER nurses more stressed than in the past month. I mean, it is not them that's causing this problem. It's not the ER that's causing the problem. They're having to work in a tough environment. And if we end up having more confrontations between EMS and hospital staff, I mean, it just makes the problem 100 times worse. So just understand, we as an EMS need to understand the emergency departments are at incredible pressure with what they have to do. So a little bit of patience on our part.
Hey, Dr. Yee, it's Summer. Can I elaborate on that? I think
Absolutely.
For a lot of our EDs, we are holding so many, and I know this is true at HCA as well. So I'm not just talking about facilities south of the river. Many of us are holding so many inpatients at our EDs that pretty much every patient we're seeing, unless they are super, super sick, is being seen and treated out of the waiting room. And so I do know there's been some concern from EMS that when they're coming in, we're sending almost everybody to triage. So I think just getting back to your teams, that it's not that we don't want to put those patients in a bed, but we really are saving our beds that are monitored for the sickest of the sick. And then we're doing all kinds of creative things, to try and monitor the waiting room. So I think just getting that out to your teams would be very helpful, because we do know some of the trucks we're seeing are frustrated that we're sending them to the waiting room, and they're just trying to advocate for the patients. And we know that.
Thank you for that information. And I think for the most part, the agencies are just happy to be able to get back to their service areas so they can answer, additional calls that are coming in. Do we have any hospitals on that would like to give us an update, as far as what's going on in your institutions?
This is Summer. I mean, I can give an update for Bon Secours. We continue to see pretty high numbers of COVID. Most of the facilities, their beds are pretty much full. I know that a lot of our ICUs are sitting at capacity. We do have ventilator capacity and BiPAP capacity, but we're starting to be really taxed with inpatient beds. On top of that, we're dealing with the same issues that everybody else is, which we're also in the middle of a nursing shortage. So trying to balance that on top of this COVID surge has been very challenging. We're doing everything we can to try and get EMS and have shorter wall times with EMS. I know there's a lot of work we're doing at some of our facilities that specifically have had a little bit longer wall time. And then really working with our facilities to make sure on VHOS that we're updating what we have open, so that between the PDC and the trucks that are on the road, you guys can really see like where's the best place to pace that whatever I'm saying, place to pace. I can't even say it, whatever, how to place the patient. It's been a long day. And that's it for Bon Secours.
Thank you. Any other organizations?
Hi, Heidi. It's Laurent. Can you hear me?
I can. Thank you, Laurent. Go ahead.
So I can speak for John Randolph and Tri-Cities-ER. We're, again, in the same situation. We're very busy, multiple holds in the ED. Both facilities are doing the best they can to manage the influx of volume. We have identified an alternative care site that we're using on days that we have enough staff that we can support it and see some low acuity patients through that site. This week, the Tri-Cities-ER hit a record number of patients. It's 192 patients on Tuesday, and that is just an incredible number for them. Particularly, they're operating through 11 beds on a good day, 9 times out of 10, usually using 9 beds. So they've been doing a phenomenal job trying to manage that volume, but we're just both facilities are seeing that incredible volume day in and day out, to include the holds as well. So, like I said, we're just trying to do the best we can. We appreciate the patience and collaboration with the EMS crews.
Thank you, Laurent. Anyone else? Okay, I have a question in the chat asking where to find the information needed when calling the PDC. On the ODEMSA website, on the home page, there is a flyer on there titled Patient Distribution Center, PDC, and in that it gives you the information that we'll ask for. And I don't see any other questions in chat that we haven't answered. Dr. Yee, any closing remarks?
I just want to thank everybody for participating in the system. This is trying times for us all, and let's just work together, because that's the only way to get out of this mess. I mean, no matter what we try to implement to fix diversion and overcrowding, I'm hoping that the COVID crisis goes away before we can actually implement it. I'm just hoping that this problem goes away so soon. I mean, if you look back to just 2 months ago, we were actually doing very well in our region. So hopefully this portion of Delta of the coronavirus goes away as fast as it came. So everyone stay safe out there, whether it's COVID, measles, mumps, TB, or whatever, and let's just work together and be kind to each other.
We have a comment from Steve Parrott. Go ahead, Steve.
Hey, everybody, and Heidi, thank you. Dr. Yee, thank you. I just want to say the accolades to the ODEMSA staff, the incredible work that they have been doing in the PDC, and for Lanny and his team at VCU for, as Heidi said, getting them up to speed on the process. And I do truly believe that ODEMSA has really enhanced the methodology and the process of the PDC through this experience, this practical experience, and I hope that will benefit the entire region. A couple of just things I wanted to make observations and comments about regarding what the RHCC is getting from phone calls and so forth that maybe wasn't shared earlier, and that is we field probably a half a dozen phone calls a day from either an EMS agency, which we relay to Heidi, or we get from a hospital system, either at the C-suite level or at the ED clinical level. And some of the things that we've learned are some of the differences in arrival times versus the PDC times. As y'all can imagine, when an ambulance is out there in the field and contacts wherever they are in their process of their patient care, whether it's prior to leaving the scene or en route to the hospital, and then their drive time, we sometimes have a different order of assignments that the PDC makes versus the number of those units that actually show up at the ED. So when we get their request or the comment from an ED that, we just got 4 ambulances or 5 ambulances in a short period of time. The order in which those ambulances may have come is all dependent on their transport time and where they were in the process between the time that they were assigned and the time they actually arrive at the ED. And we do have, some concerns that are being expressed to us. We spent the time a week ago to share with the hospital systems, again, whatever they could do to decompress and to try to get back to a sense of normal status in VHOS and diversion to try to get us, to what I call a reset point. And obviously, a few were able to do that on that particular day after that email was sent to them about a week and a half ago. The challenge is that we quickly resumed the census levels that required them to go back either on special or full diversion, which didn't allow us to change status from the black condition to code red or code green. So we are continuing to work with the hospital and the healthcare systems. We certainly appreciate all the great communications that is going on from our healthcare partners. Keep letting us know what's going on. Keep the VHOS up to date. It helps the PDC. It helps the RHCC. It helps us all. And I just want to say thank you to everybody for their continued support. And, anything that we can do, we are advocating for the hospital systems, to try to work through the process as quickly as they can to try to get us back into some sense of normalcy. So